Hi, my name is Rachel Glenn, and myself and Wendy Herndon chose to do gestational diabetes mellitus for our teaching project this semester. I will begin by defining gestational diabetes. Gestational diabetes is defined as glucose intolerance with onset or first recognition during pregnancy. Gestational diabetes is the most common complication of pregnancy, affecting between 1 and 14% of all pregnancies worldwide. Gestational diabetes is said to affect approximately 7% of U.S. pregnancies, which yields more than 200,000 U.S. cases annually. So during pregnancy, the placenta produces an excess of hormones, many of which impair the action of insulin in your cells, which in turn raises your blood sugar. Modest elevation of blood sugar after meals is normal during pregnancy, but as your baby grows and as you enter the second and third trimester, the placenta produces more and more of these insulin-blocking hormones. And with gestational diabetes, the placental hormones provoke a rise in blood sugar to a level that can affect the growth and welfare of the baby. So who is affected? Anybody can be affected. Nobody is excluded from developing gestational diabetes. High-risk populations include Asian Americans, Native Hawaiians, Pacific Islanders, Hispanics, American Indians, and African Americans. There is no known reason for why non-white ethnic groups are at a higher risk for developing gestational diabetes. So the American Diabetes Association defines 6 major risk factors for developing gestational diabetes. They include maternal age greater than 25 years, being a member of a high-risk ethnic group, family history of diabetes, being overweight or obese, having a previous pregnancy with birth weight greater than or equal to 9 pounds, and having a history of random plasma blood glucose greater than or equal to 120. So diagnosis of gestational diabetes in a prior pregnancy has also been widely published as a risk factor. In addition, cigarette smoking has widely been investigated as a risk factor for gestational diabetes, but is not consistently agreed upon in the literature. So doctors usually screen for gestational diabetes between 24 and 28 weeks of pregnancy. Traditional glucose tolerance testing has required a 50-gram oral glucose challenge test, followed by a 100-gram oral glucose tolerance test if the initial 50-gram test was positive. The most recent recommendations are actually for a one-time 75-gram oral glucose tolerance test, with only one positive required for diagnosis of gestational diabetes. So many women diagnosed with gestational diabetes will proceed through pregnancy without any noticeable symptoms. Rarely, gestational diabetes will present as excessive thirst or increased urination. So gestational diabetes can present many complications to the mother and baby. As for complications to the mother, gestational diabetes can cause high blood pressure, eclampsia, and preeclampsia in pregnancy, an increased likelihood of cesarean section, an increased likelihood of trauma to the birth canal secondary to macrosomia, and an increased risk for developing type 2 diabetes later in life. As for complications to the baby, gestational diabetes can lead to macrosomia, that is a large for gestational age baby, shoulder dystocia, or shoulder dislocation, secondary to macrosomia, neonatal hypoglycemia, neonatal jaundice, stillbirth, obesity in childhood, and type 2 diabetes later in life. I'll elaborate on macrosomia because it's one of the most widely published complications of gestational diabetes. Macrosomia literally means big body and describes infants who are large for gestational age. That means they are above the 90th percentile in weight at birth. Macrosomia can complicate vaginal deliveries. Of particular concern is shoulder dystocia, or shoulder dislocation, which occurs as the shoulders, the widest part of the baby, move through the birth canal. Nerve damage surrounding the shoulders may also result. So in the news, CNN published a story in August of 2013 regarding a 13.4-pound baby born naturally to a woman of undiagnosed gestational diabetes. Baby Jaslyn, as the baby was named, was born at University Hospital in Leipzig in Germany on July 26, 2013. Overall, mother and baby fared well. Baby Jaslyn did require several days in the NICU for close monitoring and a little extra support. So there is no foolproof way to prevent gestational diabetes. However, the risk of developing the disease can be decreased through physical activity before and during pregnancy and with pre-pregnancy diet modifications. As for physical activity before and during pregnancy, one study I read reported a 55% decreased risk of developing gestational diabetes for women who are avid exercisers before pregnancy and then through through the early parts of pregnancy. As for important pre-pregnancy diet modifications, these include high intake of fruits, leafy green vegetables, poultry, and fish, and a low intake of sugars. So management of gestational diabetes in pregnancy focuses on ways for women to keep their blood glucose within a target range through healthy eating, physical activity, and insulin therapy. Education is also an important component of managing gestational diabetes in pregnancy. In some cases, education may be provided in tertiary care centers specializing in diabetes. So a mother's blood glucose should be checked up to 7 times a day, fasting, first thing in the morning, before each meal, and 1 to 2 hours after each meal. Depending on the woman and her unique circumstances, her blood glucose may need to be monitored more or less frequently than outlined above. Blood glucose levels can be monitored at home with the use of a portable monitoring system. Target blood glucose ranges are as follows. Fasting and before meals, it should be 95 or less. 1 hour after each meal should be 140 or less. 2 hours after each meal, it should be 120 or less. And obviously, a blood glucose less than 70 indicates hypoglycemia. So diet and nutrition therapy is the cornerstone of gestational diabetes management. The literature suggests 3 small to moderate meals each day, 2 to 3 snacks at regular times during the day. For women with healthy BMIs, the literature suggests 2,000 to 2,500 calories per day. For women of increased BMI, the literature suggests 1,800 calories per day. Carbohydrate counting is crucial to management of gestational diabetes. The literature suggests an intake of 27 to 35 grams of carbs at breakfast, 45 to 60 grams of carbs at lunch, 45 to 60 grams of carbs at dinner, and 15 to 30 grams of carbs at snack time. It goes without saying that it is incredibly important that you pick nutrient-dense carbohydrates like whole grains. Diet should also be low in fiber, or high in fiber, and low in sugar and fat. This table just lists different food items and the number of carbs that could be found with each. So physical activity can help women with gestational diabetes reach and maintain their target blood glucose levels. A minimum of 30 minutes of aerobic activity is recommended 5 days per week. This includes things like walking, swimming, dancing, and low-impact aerobics. Women should avoid activities where there is a risk of falling or injury to the stomach. Obviously, you want to protect the baby at all costs. So if diet and exercise are ineffective in controlling a woman's blood glucose levels, insulin therapy will likely be implemented by the physician. Insulin orders are determined on a case-by-case basis. A woman may have scheduled injections, sliding scale coverage, or both. Patients are monitored closely and medications are adjusted frequently, and hospitalization may be indicated when target levels cannot be achieved. So as already mentioned, gestational diabetes poses many risks to the baby, including macrosomia, shoulder dystocia, stillbirth, hypoglycemia, hyperbilirubinemia, and other metabolic complications. Fetal monitoring may include more frequent ultrasounds to evaluate fetal development, amniotic fluid amount, and congenital malformations, as well as non-stress test and biophysical profile scoring 1 to 2 times per week starting at 30 weeks. As a newborn, monitoring will include close watch of blood glucose and bilirubin levels. In addition, if there are signs of macrosomia, an induction may be indicated at 37 weeks. And obviously, there would be need for a emergency cesarean section with any signs of fetal distress. So management of gestational diabetes during labor. Insulin requirements during labor differ from stage to stage. In the first stage of labor, insulin requirements decrease. In the second stage of labor, insulin requirements increase. And post-delivery, insulin requirements rapidly decrease. Glucose levels during labor are typically monitored every 1 to 2 hours. Sliding scale insulin coverage is typically ordered by the physician. An insulin infusion may be indicated, and IV dextrose should be on hand in the event of hypoglycemic events. GDM for the postpartum patient. Patient should be followed by a physician for 6 to 12 weeks post-delivery. Continued blood glucose monitoring and therapy throughout the postpartum period should occur. And pre-pregnancy consultation and early glucose screening should occur in future pregnancies. As a note, up to 10% of cases diagnosed as gestational diabetes are actually undiagnosed type 2 diabetes. Management of type 2 diabetes will require the attention of a woman's primary care physician and/or an endocrinologist. Just to wrap things up, I've provided links to 2 sites. The first is the YouTube video published by the American Diabetes Association. It's very short and to the point, a very informative resource. And the second is a podcast produced by the Center for Disease Control and Prevention, which also is an informative resource. That about sums things up. I hope you have found this informative. Thanks. Bye.